Good morning and happy Monday. Welcome to Maryland Mobile Response and Stabilization Services Quality Improvement Collaborative Meeting. My name is Allison, and I'll be assisting with any video, audio, or any other technical issues you may experience during this meeting. Before we get started, I just wanted to go over a few housekeeping details and to inform you that this webinar is being recorded. Pursuant to Maryland law, we are required to provide verbal or visual notification of recording if you continue to participate after being notified that the activity is being recorded. Your consent to recording is implied. You can raise your hand by clicking the More option next to your name in the participants box. You can also share applause, give a thumbs up if you agree with something. If you look at that menu bar on your screen and click on the Reactions tab, it also looks like an emoji icon. If you have any questions, please feel free to put them in the chat box, but there will be some moments during the presentation to ask the presenters as well. Feel free to step away for any bio breaks needed. And again, I'm here to assist. So if you have any questions, please send me a private message in the chat box. With that, I will turn this over to Jen, and I hope everyone enjoys the presentation.
Thank you, Allison. Welcome to the Statewide Mobile Response and Stabilization Quality Improvement Collaborative. My name is Jen Lowther. I work at the Institute for Innovation and Implementation, providing technical assistance on mobile response and stabilization in Maryland. It looks like folks are real pros at pros with Zoom because they've entered into the chat already, and I appreciate that. If you haven't, please enter your name, organization, in the county in which you work, and anything that your favorite thing about spring. I know it didn't cooperate this weekend and it snowed in many areas of the state, but things you're looking forward to as the weather does turn and Mother Nature cooperates. So thanks for doing that. Our agenda is pretty robust today. We will talk through best practices and customization for children and families, presented by Liz Manley, and then we'll have BHA provide us with mobile response and stabilization updates and a discussion related to dissemination of funds, guidelines for provider contracting, the crisis assessment tool CAT implementation in Maryland, and review of draft statewide crisis system core metrics and implementation. We'll then move into the last section, which will address TA, specifically readiness, assessment, and development of individualized TA plans. And as Allison mentioned, we'll break after the major sections to allow you all to ask questions unmuted, and please ask questions in the chat as we go along. Just to review the purpose of this Mobile Response Stabilization Quality Improvement Collaborative, it's intended to share updates on the design and rollout of mobile response in Maryland, problem solve and make strategic decisions to improve that implementation and expansion of services in Maryland, develop new partnerships, promote peer interaction among you all, share national best practices for children, youth, young adults, and families, and review data and utilization as numbers come in. The approach and the process to this collaborative uses a continuous quality improvement framework. And it's intended to collaboratively review implementation statuses, successes, barriers, and practices as we go along, and share across different jurisdictions and align with BHA's strategic vision. With that said, I'm going to pass this on to Liz Manley and let her talk about best practices and customization. Thank you, Liz.
Thanks, Jen. I am so very happy to be here today. You can't know how excited I am to talk about mobile response and stabilization and the work moving ahead in Maryland. For those of you who don't know me, my name is Liz Manley, and I work for the Institute for Innovation and Implementation as a senior advisor, working on children's behavioral health systems design across the country. Mobile response and stabilization is a big topic in my world these days. So I'm very, very happy to join you today to talk about what mobile response is, what it does, and how it can be helpful. I think we skipped one slide ahead. Not yet. Okay, we're good. So first question I have for all of you today, and I have a few questions throughout the course of today's discussion, is really, are families, youth, and young adults with lived experience involved in your crisis systems design? So if you could take a minute and complete that question, that'd be great. You guys are really super good at this work by now. That's awesome. So we're seeing that most are, so that's great. Let's see, we are at 85, 83, 80 over, well, not sure. Okay, those are good answers, right? So right now we have, most of you already have young adults, youth and young adults with lived experience involved in your crisis systems design. So that's exciting, 66%. 24% of you are not sure. This is one of your homework assignments to go back and to begin to think about or ask questions around. And for those of you who don't have it, the question is why, and are there things you can do, right? So that's the next step for all of you in this discussion. So next slide, please. There we go. So mobile response and stabilization is a term you're going to hear a lot today, or MRSS. MRSS is not a new concept in across the country, although it's very new in many states across the country. An idea of customization specifically for children is really a new idea for lots of states as they're really working through some of the implementation of 988 and working through how to really customize for children. What you should know is that mobile response and stabilization in most states is the anchor, right, for the crisis continuum. And what that means is it allows us to really think about the individualized needs for children, youth, and families who are beginning to experience an escalation within their families. So they have a family-defined crisis and they need assistance, but they don't even know what assistance that they need. And so what the customization of mobile response and stabilization does is allows us to get really upstream when families are experiencing these crisis situations. So really important part of the work. What is also important to know is that when we talk about mobile response and stabilization, when we talk about MRSS, there are real parts of this work that we have said are really best practices, including that the crisis is defined by the youth or the family, right? The youth and the family generally in coordination. So it's really important to know that that's one of the drivers of this. Next slide, please. So mobile response and stabilization design and intent really is to meet the needs of children, youth, and young adults and their parents and caregivers. So in other words, we recognize that young people, children, youth, and young adults don't escalate. They don't have their crisis in a vacuum, if you will, right? The crisis is really from the perspective of, you know, the parent watching as their child is experiencing some challenges, not know what to do. Maybe they're getting calls from the school, maybe their child's refusing to go to school, maybe they've seen an increase in behaviors, but whatever it is, it's now not just the child's challenge, right? It's the parent and the caregiver and the family situation challenge. And so it's really important for us in the design to not just think about what does that young child need? What does that 16-year-old need? What does it mean for that 15-year-old to not go to school? We have to think about what the impact of the parent and the caregiver, use those parents and caregivers as really helpers in not only solving this particular challenge, but what happens next. Next slide, please. And if you've heard me present, this slide is in every presentation that I talk about across the country, because language is, first of all, one of the most important parts of the shift and change in systems design and transformation. It's also the least expensive one, right? It is one that we can all do together. It doesn't require policy changes even. So I'm just going to go through this really quickly and let folks know that when we talk about language of hope and partnership, we're really talking about children, youth, and young adults, not clients, cases, or consumers. We're talking about parents and caregivers, not mom and dad. We're not talking about the role base of mom and dad. We're talking about children, youth, and young adults. We're talking about family and caregivers. We're talking about not those families. We're not talking about, we are also talking about treatment and treatment interventions. And it's really important in this work to recognize that the words not motivated aren't part of our vocabulary, and we don't talk about young people as if they're not motivated. From my work in over, I don't know how many years, what I have found is that I never expect a 16-year-old to be motivated. It is my job to figure out how to motivate, to figure out how to help and be a helper to that young person. And so Engagement skills are incredibly important in the work of mobile response and stabilization. And we're going to focus a lot of time and attention on how to engage both young people and their parents and their caregivers. We talk about transition, not closing or terminating. The idea of terminating 13-year-olds is just way too much for me to manage today, for sure. And we talk about young people who are missing, and by that I mean they're not where we think they should be. And because they're not where we think they should be, we think a system should be designed to help families go find them, bring them back, and find out why they went missing in the first place. And that the issue of runaway really puts the onus of a young person. And what that means is that we hold them responsible for a behavior that may or may not even make sense within their work and within their world. And so what we know is that when young people are not where we think they should be, and we call them runaways, that means that the system almost begins to think about them as throwaways. And that's a really important concept as we do this work. So when young people are not where we think they should be, we find them, and we bring them back. When I was the assistant commissioner in New Jersey, law enforcement told me in no uncertain terms that if we called and asked them to help us find a young person who was missing, they would help 100% of the time. And that if we called and said that the young person had run away, they wouldn't. And so really important, the language and what it does in getting adults to mobilize to help young people. And then family time, right? We don't want to talk about, we don't talk about resistance. We don't talk about manipulative behaviors. We really talk about what's going on for this family and what do they need. And we really want to keep young people in their homes, schools, and communities. Next, please. So poll number 2, next question. Does your child's crisis system design include response without law enforcement accompaniment unless a risk or safety screening tool demands? All right, we got a lot of yeses. This is really exciting for me because this is one driver for change within the children's system. So really important. This is great. We have a lot of yeses. We have no no's, 1 no or 2 no's, okay. And possibly still in development. It sounds good. This is part of the work that we're going to be doing together. Okay, great. So most said yes, that's great. And let's define what, real quick, what does that mean, right? When we talk about law enforcement and law enforcement coming, what is where does that happen, right? Where would we use law enforcement, right? So we would use law enforcement only in the real idea of weapons being included in the conversation. And we can talk a little bit more about that later if that's helpful, but it's really important to know that the impact of law enforcement on young people is not just one that leads us in the short term to work that has to get done. It really is a long-term issue for both young people and their families. Next slide, please. Okay, I wanted to talk real quick about children's versus adult crisis models, because sometimes we get a little confused about this. And I think it's really important for folks to understand the underlying or core components of what mobile response and stabilization is. In the children's world, that single point of access is really about a place for parents to connect, get help, ask for help, and get it, right? So our underlying philosophy is a parent asks for help, we send it, right? They say, we don't know what to do, we send help, and we send help in all situations. And that may not be where you start, but it's certainly got to be the long-term goal for mobile response and stabilization, is that 100% of the time that families ask for help, we send it. And the air traffic control model that some adult systems use across the country, in that adult control, air traffic control model, about 80%, the goal is about 80% of those calls are de-escalated over the phone. I just want to let you know that families across the country have said to us that if you want to de-escalate them over the phone, the chances are of them using your system again really diminishes, because they don't need that, right? That's not what they're calling for. What they're really calling for is they want someone to show them, to walk them through, to help them figure out what's next. And they want that to happen in a way that is really family friendly in their own homes and communities whenever possible. So that single point of access and care traffic control model is really important. That the crisis is always defined by the parent or caregiver, not other systems either, right? It's the parent picks up the phone, asks for help. It could be somebody on the line with them. Law enforcement could be on the line with the parent or caregiver. You know, schools often are on the line with the parent or caregiver, but it's the parent or caregiver that we're asking to be part of the solution. And so it's really important that we're not making decisions without them. That there's a comprehensive children's assessment, and that means that we're gathering information that lets us know, how serious are the challenges ahead for this child, youth, and family, and more importantly, what are some of the ways in which we can make sure that they get the assistance they need at the time they need it for the duration. And that's really takes into consideration this idea of sequencing for young people when an intervention like outpatient might be helpful, that we always respond without law enforcement, and that we're specifically training the workforce around how to work with children and families. And this is a really important concept. I talked to a lot of crisis folks across the country, but certainly did a lot of this work when I was in New Jersey. And a lot of the folks who were intervening with young people told us that we were pretty afraid of working with 10-year-olds because they weren't trained to work with 10-year-olds. This was true for folks in the emergency department. Certainly in New Jersey, it was an overwhelming answer to one of my questions for folks. So really important that we have specifically trained workforce who knows how to engage 10-year-olds, 15-year-olds, 20-year-olds, knows how to engage their parents and their caregivers in a way that is meaningful. And that we're designed to interrupt care pathways, which I'll talk about in a second because it's really important, and stabilization services, which we'll also talk about. But that community connections is the core of the work. The goal really is not to connect to a formal intervention like outpatient. The real goal is to reestablish these community connections with family, with communities, with schools, all of the places in which young people experience healing. Next slide, please. Poll number 3. Does your child's crisis system design include round the clock, 24/7, 365 response to caller-defined crisis in home and community-based settings such as schools? Yes, no. So, okay, we got some good stuff already happening in Maryland. Very exciting. 365, we're going to the home because the parent called, asked for help, and we're sending child-specific folks there. That's great. Almost there. Okay, so it sounds like the majority of you are in this place. Some are still trying to figure it out in development. Some say no. For the folks who say no, like this is the work that we want to really think about over the next period of time. And we also want to make sure that those who are not sure that they get the answers to that question. Next slide, please. So mobile response and stabilization, unlike many other things within the children's system, is really designed to meet a parent's sense of urgency with a sense of urgency, right? It's a core principle within a systemic care. Is meeting sense of urgency that parents and caregivers experience when their child begins to demonstrate behavioral changes. In other words, we really are trusting parents to tell us that this is really overwhelming what they're experiencing. And so we don't put any value or judgment on that. Parent calls, asks for help, and we go. This is why mobile response and stabilization doesn't have the word crisis in it. Not because the young person or family isn't experiencing a crisis. It's because professionals tend to get in the way of understanding what the family's definition of crisis is. And I certainly saw a lot of this in the beginning days of mobile response and stabilization in New Jersey, when professionals like me would say, wait a minute, they haven't thrown a chair yet, right? So the goal is to get there earlier than the chair being thrown. And so we want to get there when the parent is experiencing this sense of urgency. The other important part of this or concept that we're really trying to get to is we're really trying to help parents and caregivers in what is generally their first touch on a public system to experience that public system in a way that is meaningful and can really impact that that young person and their families for the rest of that individual's life. It's like when you have a pretty bad experience calling somewhere, like, I don't know, calling Verizon, and you get that feeling like that's not going to work, right? And what we want families to experience, that the public system is responsive to when they're feeling a sense of urgency. This is a really important concept in systems transformation, and one that's really important to pay attention to. So in other words, every time they call, we're going to be responsive. Every time they ask for something, we're going to be helpful. And in doing that, we get to change the full trajectory of the experience for that young person and their family. Next slide, please. So mobile response and stabilization is really about leadership, right? And when I talk about leadership, I'm talking about leadership at the ground up and the top down. It requires state engagement and leadership. Certainly we're seeing that, and Maria's done such great work in trying to bring this forward. But we also need leadership at the ground level too, right? We need parents and young people to help us know when we're doing well. We need leadership in organizations that say, we're going to put these resources in and we're going to train and do what we need to do because it's the right thing to do. But that means that we have to create the condition that allows for shift, because the shifts have to be around language and culture, necessary for parents to see mobile response and stabilization as helpful, right? So that language slide becomes important, right? Not thinking about folks as client cases, consumers. If a family thinks of themselves as a case, they're less likely to pick up the phone and call for help. We want to prioritize the voice of parents and caregivers in determining the crisis and the action steps to meet the needs of each of those youth. And what that means is that sometimes we have to put what families want at the priority place in terms of how we're going to work with that young person and their family. We want to create feedback loops that focus on meeting the needs, engage communities and supporting children, youth, and families. That means it's broader than just making sure that there's outpatient, intensive outpatient, or partial care available. Those services become less necessary, in particular, partial hospitalization and partial care, if we get this work right. And then we want to focus on interrupting care pathways that lead to restrictive services that pull young people from their community engagements. Next slide, please. So this is what a system, a good and modern system looks like, and some considerations for mobile response installation and availability, right? So we want to pay attention to the care pathway that takes young people into all of these places, right? So, you know, what happens for young people is there's a concern, you know, the school might be calling and identifying that the young person is struggling, that there's trouble where the family is experiencing those phone calls and beginning to escalate. So we want to make sure that we're looking at where can we interrupt from when we begin to see that things are happening for that young person and family, and when they enter a formal service. When does that happen that we help with that young person? And what I mean by that is many young people, when they begin to demonstrate challenges within schools, as an example, right? They're suspended, they're suspended from school, their grades are failing, they're not communicating, they won't get off the couch. These are a lot of young people that mobile response and stabilization is really powerful in its intervention. And the reason that is because we're addressing it really early. And we're not saying, to that young person, you must engage in outpatient, you must engage in a formal intervention. What we're saying is, we want to know what happened to you. We want to know what's going on for you, and we want to understand how we can help you get back to school, get back to the activities that are really important to you. And those interruption points become important because it makes everything else in the system work better if young people are entering into formal services when they're prepared for them. Next slide. So those interruption points, right? So the care pathways, if you will, are really important. And this care pathway idea is one that was really built into the medical world, but important for us as we are thinking about how do we redesign systems to meet the needs of young people, children, youth, and families, right? So the places in the pathway that system leaders need to intervene to change experience of families and address the identified problem. The interruption points are opportunities for system leaders to change care pathways and create new pathways, right? So this is why the conversation often starts with what happens to young people who are in emergency departments, inpatient care. It starts there because what we know is that emergency departments are not the best place for young people to be, right? They tend to be a traumatizing experience for young people. Their care that they get there is not consistent with what is necessary for young people to be successful. And so with all of that said, it's really important for us to figure out how to interrupt those care pathways at a very early point. Next slide, please. And the core components of mobile response and stabilization, there are two parts of this, right? And so those two parts include that 72-hour component where we say, when we pick up the phone, parent asks for help, we send it, the family defines the crisis, there's crisis de-escalation that happens, there is identification of trauma-informed care, right? So tools that are gonna help us identify and support families who have experienced trauma. And then there's that really important assessment that happens. So that's one core component of this work. And the other core component is the 8 weeks of stabilization. So they're two separate components, right? But they're interconnected. That 8 weeks of stabilization includes building to the community supports we talked about, reconnection with activities such as sporting activities, arts such as acting and painting, the extracurricular activities at school. We're looking for some in-home clinical support for some young people and their families, not all, and that connection to a higher level of support might be determined necessary for some of these young people. Next slide. So in line with best practices, there are some core components we want to talk about, right? So those two components we just talked about, that 72-hour and that 8 weeks of stabilization, are really melded into this chart as we see it, right? So there's the screening and assessment component that might be happening really early from pediatricians, some schools, all kinds of things. And there might be some ability to connect to home and community-based services prior to mobile response and stabilization. And there's ideas like planned respite as an example, which are really helpful. But then families are beginning to escalate, in terms of their anxiety, their worry about what happens for their child. And with that, we want single point of access where the triage is asking the questions around safety and around why the parent called today, and engagement in the home, that there's the in-person mobile response where de-escalation is happening, there's a crisis assessment, that safety plan is developed at that first 72 hours. That peer support sort of goes across multiple parts of the continuum and helps to link back to community-based services and supports. That there's an intensive in-home in the stabilization period, right, in that 8 weeks of stabilization that includes multiple components, including a care coordination component, some clinical intervention as necessary, care coordination for all young people getting stabilization, and intensive in-home for many of the young people who are getting in, stabilization services, but not necessarily all, and that there's some crisis respite care, what might include some relief for parents, right, during that period of time. And in very small circumstances, short-term residential beds might be necessary in some particular situations. Through all of it, that there's availability of psychiatric consultation, telehealth as an example. We want all young people to have access to telehealth consultation, and we want to ensure that things like medication breaks, because young people can't get medication that they need, are managed really effectively and don't drive either youth or families to emergency departments. Next slide, please. So poll number 4, does your child's crisis system design include ongoing home and community-based services to provide care for 6 to 8 weeks following initial crisis and coordinate with other child family serving providers and systems for ongoing care? All right, we have a lot of yeses, about 80%, possibly still in development. Okay, they are almost there. Okay, good. So we're at 77% say yes, 5% says no, 18% says possibly, still in development. And all of you are sure of what you have. So that's good news. Thank you. Next slide, please. I wanted to spend a couple minutes talking about this, and you're going to see this slide again later in the presentation around that technical assistance component, but it's really important. So I just want you to know it's not a mistake that it's in the slide deck twice. It's in the slide deck twice because in order for us to really understand what's happening for children, youth, and families in your system, it's important to develop a map and a pathway. So we need to understand what families' experience really is, and then what the interruption points are. And so with this, you'll see in the middle, right, that arrow in the middle, it is the family-defined crisis called mobile response and stabilization, right? We want to make sure that families are getting what they need at the time they need it for the duration. And in order to do that, we have to begin to ask these type of questions of families. And then later you're going to hear in more detail this slide, but I wanted to make sure that you saw the interruption of the care pathways is really important, and designing a system that takes into consideration these challenges is incredibly important. Next slide, please. This is just another version of that care pathway, but it helps us sort of organize around what is happening right now, right? What are the things that are working? As an example, the state's focus on building access to mobile response and stabilization is really important in the systems design, right? In the work that's happening at the state level, and then will have impact on the local level. And then at the program level, what response, your protocols, your staffing, right? How that works, how you incorporate the assessment tools, how those assessment tools are being used, all impact on the experience of children, youth, and families. Next slide, please. And we can't forget to check ourselves. Someone to contact, someone to respond, a system to support is really important part of this work. So we want to do regular reviews of system utilization, including referrals and eligibility criteria. Are we partnering families at the right time in the right place? Is anyone left out? All of those things are important. We want to focus on the workforce. This is a true shift in the workforce. And if you haven't really experienced that yet, this true shift in the workforce, that the workforce really needs to begin to think about this work very different in the skills that you need, and fidelity to the model itself, and access to coaching, and which we'll hear more about later, and certainly in the policy and procedures reviews and how we think about it. As systems evolve, don't forget to check around what is working to ensure it continues working amidst future reforms. Next slide, please. And setting the vision. Maryland is committed to designing and implementing a mobile response continuum that is customized to meet the needs of children, youth, and families, that provides timely, relevant services and supports to prevent escalation of challenges and poor outcomes, and uses the child and family's definition of a crisis. Really important that it's individualized and trauma responsive, and that it really connects to the larger systems, and will push for other systems reform in this work. That's culturally and linguistically responsive. That means that we are working in the communities that young people come from, that the workforce is coming from those communities, and that we're listening to what folks are using. In other words, mobile response and stabilization is an equalizer as well. It allows us to address equity by having families be able to access care at a single point of time without really challenges around getting the workforce that they need, the workers that they need in order for them to be successful. And it leverages the strengths of children, youth, and families. And I would argue leverage the strengths of communities when we do that work well. Next slide, please. And this is the workflow, right? So this is the way that we're envisioning this work happening in Maryland. We know from implementation science that we're going to learn a lot of lessons, but the BHA will be partnering with families, youth, and provider organizations and state and local public child and family serving agencies to design, install, implement, evaluate, and sustain mobile response and stabilization for children, youth, and young adults and families. And that we envision Maryland's mobile response and stabilization playing a critical role in providing care in the least restrictive environments appropriate to meet clinical needs and maintaining children safely in their homes, schools, and communities. So a really important part of this work. Next slide, please. Poll number 5. Does your child's crisis system design include mobile response staff with trained family and youth peers? Yes. Okay. Whoop. Almost there. Guys are flying. You're doing great. Okay, so we have 47, what? Nope, 49% say yes, 15% say no, 33% say possibly still in development, and 3% say not sure. All helpful. Thank you very much. In that slide, I just want to say that youth and peer support is part of mobile response and stabilization, is really the work of the future and where we want to move this work. Our young people are really important in the conversation. Parent peer support has been the driver of innovation in this country for a long time when it comes to systems reform. So we really want youth and families sitting not only at our policy table, but certainly at our table of intervention. Next slide, please. And systems coordination requires us to partner with child welfare, juvenile justice, family courts, education, pediatricians, and primary care, law enforcement, emergency departments, community organizations. And what that means is these are all partners, not that we just want to engage in parts of this conversation. We want to engage them in the whole conversation when it comes to mobile response and stabilization. Eventually, we want to train all of these folks to understand when and how to use mobile response and stabilization so that they are part of the solution in terms of intervention with youth and families. Next slide, please. And just lastly, the goals of mobile response and stabilization are to maintain youth in their current living situations, support youth and families in providing trauma-informed care, promote and support safe behaviors in home, schools, and communities, reduce the use of emergency departments, hospital boarding, and detention centers due to behavioral health crises, and assist youth and families in accessing and linking to ongoing support and services, including intensive clinical and in-home services as necessary. Next slide, please. So I'm going to, before I go, I think I have 2 minutes to take questions from anyone that has one. Jen, did you have any?
Yeah, Liz, I see 2 in the chat. Thank you for that presentation. It was really helpful. The first question we have from Heather Dewey from Baltimore County, is there a place for youth to define the crisis in addition to, quote unquote, the crisis is defined by the parent caregiver, encouraging youth to also use the crisis response system directly?
Yeah, there is, right? A couple of things to think about, though. As you think about young, first of all, if they're over 18, they absolutely are going to find the crisis. There's no doubt about it. If they're under the age of 18, they're still living at home. We need parents in the conversation. So really important for young people and parents to be at the table together. And I would argue for a young person who's defining their own crisis, and is willing to engage in outpatient care and willing to engage in clinical interventions, that there may be other things for consideration for those young folks. But certainly, yes, we want young people at our table. It's not uncommon for young people to bring their parents along as they use a service like mobile response and stabilization, but it's incredibly important that parents be part of that conversation as well.
The next question I probably can answer is from Jenna Wagner from Beat Cars in Baltimore City, asking whether there's a specific training for response model that is encouraged. And the answer is that we have a national curriculum that's in development that will be customized for Maryland. And the rollout for that is likely, I'm thinking, end of summer is what we're looking at right now. And just so folks know, the CAT, Jay will talk a little bit more about the CAT implementation later, but as part of that, we're integrating the best practices as part of the CAT training, and those 2 trainings that will be available statewide are going to align and provide both the best practice training as well as the crisis assessment tool training. Anything you want to add, Liz, to that?
No, I just want to say this. It's a really exciting time for mobile response and stabilization, and Maryland is joining the conversation that's happening nationally. This is a conversation that we're having in too many states for me to count right now around building mobile response and stabilization. So you're in good company around the work that's happening. And I think, and still not just in good company, I think you're going to lead the way of the way it rolls out within state implementation. So thank you for the opportunity to talk about it. It's always a pleasure to join you. And if there's any follow-up questions later, I'm happy to take them.
Great. And then I'll just jump in on the one question from Anne. The question was from MCF, why 12 plus is the age listed? Liz, do you want to take that or do you want me to?
You can take that, Jen.
Yeah, I mean, there's just discussion on trying to align with the voice of the youth in Maryland and align with statute that's changing. It's lowering in age when youth can access treatment on their own without consent from parents, at least reach out for help. So, it's a bit of a moving target, the age, but that's what we put in here in terms of calling for help in this system. So it's something that we can continue to have the discussion about what's appropriate.
Yeah, Jen, just to piggyback on that, I mean, the state's position with that is that it's really up to the clinician that's to make the determination of, is this, adolescent ready and capable of making that, independent request, or whether we need to. Obviously, we want to get family in as quickly as possible, but in a crisis situation, that final decision is up to the clinician that's directly involved with them.
Listen, I'm just going to add one other comment on that, and that is the experience that I certainly have from over 20 years in systems work in New Jersey is that this particular scenario does not come up in the world of mobile response, right? So it does come up often in the world of outpatient and should we connect outpatient. It doesn't come up in the world of mobile response because of the upstream nature of mobile response and stabilization. Parents are more likely to engage. In particular, if you can engage your community partners in ongoing conversations and have schools work with you on when and how to use mobile response. So all of those things really make the rest of that conversation less worrisome because families do tend to come to the table more openly.
Well, I think we'll move on to the next section. Please, if there are additional questions you have related to best practice and implementation, please just put them in the chat. We'll either answer them at the end as we have time, or we'll certainly answer them later if we don't get to it at the end. So keep them rolling. I appreciate that. And Maria, I'll pass it on to you now.
Sure. So just kind of continuing on where we are going with MRSS, let's move forward. Wanted to highlight the press release that finally came out March 18th. The announcement from the whole health department about $17.7 million in grant funding that has gone out or in the process of going out to support local behavioral health authorities, behavioral health walk-in centers, and urgent care centers. Of that, 15.4 million was coming out of the CIS division to expand MRSS. Current MRSS counties, so kind of our early adopter counties that were fairly far along in this model, include Hartford and the greater Midshore region. Areas that will be expanding in what we're referring to as phase 1 include Allegheny, Garrett, Washington, Frederick, St. Mary's, Calvert, and Charles. I wanted to highlight in some of these regions, there was very little existing when we started, and that's why they were selected to move forward. These decisions were made as part of a kind of collaborative across all of the Maryland crisis or comprehensive crisis response model work groups. But some of those counties had very little. And so part of what we're funding is actually bringing up a mobile response team at all, and using that as well to then be providing the MRSS response. Next slide. Phases to MRSS implementation. Targeted technical support will support MRSS implementation in phases 1 and 2 counties over the next year. Generalized technical assistance will be available at all counties. And again, sort of how we transition through these phases is up for consideration, both of what funding continues to come in. We certainly heard under the State of the Union speech from Biden obviously pre the issues over in Eastern Europe right now, but that there was more money coming through in support of mobile services, not only for children, but across the age span. So that will help impact how rapidly we're able to move these things forward. Next slide. So new BHA MRSS documents are available. The 2-page version of the vision paper, as well as the MRSS environmental scan. They'll be shared with members of this group after today's PowerPoint. They should also be posted shortly on perhaps the BHA website or perhaps the KIS webpage under the BHA website, depending on when and how things move from the broader BHA page to our page. So next section is certainly guidelines for providing provider contracting. I'm going to highlight that these are really guidelines. We're started to help define and lay these things out. Obviously, we're still working through with counties, both what exists and how we modify these things moving forward, and cleaning up the language with the collaboration again of the entire, sort of BHA crisis system work group. Let's go ahead. So again, programmatic name in areas where we're going to be expanding and bringing this into counties that already have some of these services or incorporating in pieces of these services. Counties that don't have everything, we're helping to provide language for a comprehensive group across the age span, but this is going to highlight the language and the expectations for just the children, youth, young adult services, MRSS formal model. Award period. Again, this is laid out as the it's the state fiscal year. Some of our funding doesn't align with that. All the counties are more than familiar with working with that, complicating factor and how we have to write our grants and awards. Providing, again, mobile response teams for up to that 72-hour intervention, stabilization services, up to 8 weeks. Obviously, not everybody needs the full 8 weeks, but it's available where it's needed. I'm going to highlight also the age frame. Again, these are coming from examples from other states, coming from guidelines. We need to work through with Medicaid in terms of Medicaid funding, how exactly we apply that young adult period. Would love to be able to go 18 to 26 and be in alignment with sort of commercial insurance plans and the ability of young adults to stay on a parent's plan. We've got to work and see where things go in accordance with Medicaid and what recommendations are coming down and what they're able and willing to support and comfortable supporting giving our funding. So statement of work, MR mobile response teams provide short-term service that's mobile, on-site, face-to-face response to youth experiencing behavioral health crisis. Going through all this, it's very much language we've shared before, consistent with that. Services lasting up to 72 hours and keeping things moving forward with that model and that process. Next slide. So again, giving you some guidelines for statement of work, what stabilization services are, what are MRSS best practices and principles. This we're probably going to incorporate into some sort of generalized attachment to be able to provide to counties to their contracts. So that all of this doesn't land in the final contracts. Response times, again, ideals where we want to go 24/7, 365. Looking for an average response time within 60 minutes of the call, recognizing some places and sometimes calls are going to be able to be responded to much more quickly, giving us a little wiggle room because in some jurisdictions, getting from point A to point B in 60 minutes is not reasonable. And we're working to where we can with that. One thing I wanted to highlight, since it has come up, is the opportunity for on-call kind of overnight services. We know those are not times that there's a lot of responses. So having even a regional team or a much broader team being available to respond to those calls when they come up, but you're not needing to have a team staffed fully at all times. And there's some flexibility in some of these that are coming through again from CMS guidance around what will and will not get federal match on these services. And continuing down, MRSS desired outcomes. This is coming very much from the data work group, again, statewide, BHA's model for Maryland crisis. And these are, goals that we would like to be providing. Go on to the next slide. And again, things that are going to be less numerically measurable, but certainly seeing bigger impact from these services, as well as, specific data that we will be reporting. Staffing requirements, again, some guidelines coming from, national expectations and models and what's working in other states, laying through, what we're looking to do. These are, again, subject to kind of finalization within Maryland itself, but looking to how can we create teams that will be able to be filled. I mean, we know there's a job shortage out there. Not job shortage, a staffing shortage in Maryland at this point in time. And we're really struggling with that and struggling to know how we can get our teams up and running and working. And there's, some opportunities for certainly workforce development over time. And we're also exploring how we can support those efforts. And finally, performance requirements. This is more of the data that counties will be reporting back to us and laying this out as well. Next slide. So it's continuing on, pretty standard quarterly reporting back to BHA. Eligibility, population, again, we've talked about the young adult space and how we need to work through that. Geography served. Access, single point of access. That's going to be as everything evolves in the state, potentially our 988 system being referred to local call centers, and those centers being trained on how to pass that over to the mobile response teams to be able to come out and do this response to children and youth in their home or in their location. Language, obviously, translation services is standard within all of this, and then training requirements are highlighted down at the bottom. Next slide. Assessment tool, Jay will continue on, but we've certainly been talking about the use of the CAT as a standardized assessment tool across all of these. And then outcomes tracked, again, coming out of the data work group within Maryland's crisis response work groups. Then again, you've all been coming to these quality improvement collaboratives, continuing to participate considering to participate in the sort of local meetings around this, both technical assistance and ongoing monitoring. That's the quality improvement process. That's key to being able to get the system up, running, and effective, and maintaining that sort of higher fidelity component of this. We need to be continuing to look at what isn't working, how do we make things better? And it's that model will continue to be supporting in Maryland. Next slide. All right, pass this over to Jay, and we'll hold questions on both of these two sections until he and I have finished.
Okay, good morning, everyone. I want to sort of continue on. We've heard in both Liz's presentation and Maria about using a uniform crisis assessment tool is critical in the development of the crisis system in Maryland, as well as putting together a uniform set of data elements that will be collected across the system. Maryland, and with the crisis data and assessment subcommittee, we reviewed and selected reviewed several tools and selected the crisis assessment tool as the tool for use in Maryland. And I'm going to walk through it today to sort of describe to you why it is a good fit for Maryland. The Maryland CAT was developed from the Child Adolescent Needs and Strengths Assessment tool. It's a subset of items from that tool, and it really serves as a multi-purpose information integration tool that is designed to bring together and coalesce the output of an assessment process. It's also really focused on creating a shared vision for the child youth serving system, meeting, communicating with children, youth, and families and other partners in the system. So it creates, it really allows for effective communication of this shared vision across all levels of the system. So it sort of gives us a common language to talk about the needs and strengths and issues a child, youth, and family are experiencing within the crisis situation. The tool, importantly, was developed mostly from a communication theories perspective. Many tools are sort of go through a traditional use psychometric theory. This was really meant to really coalesce information and to use it to really manage the system. We talk about that. We can go to the next slide. As TCOM, Transformational Collaborative Outcomes Management. The CAT is really developed as a TCOM tool, which really supports the values that Liz talked about for our crisis system. The TCOM approach is grounded in the concept that various perspectives in a complex system are often at odds with each other. So the core concepts, the system is really focused on personal change, is not, and is really intended to be transformational. And when I say transformational, really focused on helping children, youth, and families change their lives and change their situations. So it's not sort of primarily a clinical assessment tool. It's really focused on how do we move this youth and family to a better situation. So in order to do this, we need to create and communicate a shared vision that is really focused, as I was saying, on the well-being of children and their families. The shared vision involves really the participation of all key partners. And this is really essential to really instill trust, building trust with the family and the youth, as well as other partners in the system. So we're working together to improve lives of children, youth, and families. We use and then the system, the data from the CAT is really used, or the information, I should say, from the CAT is used to make good decisions about having an impact on that youth and family across all levels of the system. Next slide, please. So what is the CAT? The CAT is the crisis assessment tool, like I said, was developed as a with sub items from the CANS tool. It's person-centered, really continuously aligning the work of all persons with the identified strengths and needs of children and families. So it really is looking at, both the needs, the functional issues going on, as well as the strengths that child and family is showing. And it's captured across multiple informants and multiple information sources to really develop a consistent and comprehensive set of strengths and needs that we can use to help achieve collaboration and sort of a consensus-based assessment. And as you can see, the tool is really very well fitted to how we want to move our crisis system. It's collaborative, it's transformational in its approach. It's really focused on strengths of youth children, youth, and families. And it really allows us to coalesce and communicate information across all individuals working to assist that child, youth, and family in the crisis system. Okay, next slide. So like, just to summarize, the CAT is used to summarize information gathered through a comprehensive assessment process. It is an information integration tool that identifies the needs and strengths of children, youth, and families that we're working with. The goal is really to move transformational change and impact children, youth, and families. The CAT can really be seen as a summary tool rather than a diagnostic tool. It really summarizes the information that then can be used to really manage both what's going on with the youth and family, as well as how the system is doing. So next slide. So in terms of the rollout of the CAT, we have started. We do have a Maryland CAT tool that we developed with the developers that is unique to Maryland. The Institute had done a first round of training in March, just a little earlier this month, a few weeks ago. The Praed Foundation, who is sort of the owner of the CAT tool, will host a stakeholder information session in April. It may be actually in May. We're inviting John Lyons, the developer of the tool, to really come and talk to a broad range of stakeholders about using the tool, how it's used for transformational change in the system, how it can support our crisis system. And in May, we'll also start training the next cohort of counties using the CAT. So those trainings will roll out in phases as different jurisdictions are ready to move into this, the MRSS work. And then later in the fall, the Institute trainers will work with the Praed Foundation to develop a community of practice training for all counties that have already been trained on the CAT. And that is really to continue to instill how this tool can really be used to focus the work that we are doing with youth and families in the systems, how we really use the tool to transform our system. Next slide. So some of the next steps, the state will continue to transition crisis response systems and providers to implement the one uniform tool for children and youth. This is for children, youth 5 to 18, to streamline the assessments, data collection, and outcome. Your jurisdiction based on contracts and readiness will be invited by BHA to attend the next training scheduled for May, and then as they're scheduled, going out as well. Early adopter jurisdictions will be part of the leadership to put the CAT into practice and to adapt as needed. We have developed, as I said, the Maryland CAT tool, but we want to use some of the initial use of the tool we'll use to sort of make some changes, and we'll want to get feedback from you on what's working and what's not with the tool, so we can make any adjustments we need to. So it really works with your system. And I think that's another important component that, to think about, that the CAT really needs to be integrated with the workflow of your crisis system. It's not sort of an add-on tool that you have to do to capture data. It really should be thought about as a tool that really is used in conjunction with your crisis services. And there will be more discussion of that as we roll it out, as Jen talked about, in terms of sort of coordinating the CAT training with best practices. The BHA will track the completion of training and the certification of the workforce with the CAT. There's a certification process that once you're trained that individuals will go through, so we can be sure they are understanding the use of the CAT and using it appropriately. And BHA is now working with the Parade Foundation and our adult team to develop a Maryland CAT tool that is specifically designed for adults over 18. And this tool is really based on the ANSA, the Adult Needs and Strengths tool, also developed by the Parade Foundation. So there's actually a meeting this week with the Parade Foundation to sort of begin that work with the adult tool. And we're also in the process that I'll talk about in the next section a little bit of developing and implementing a statewide data collection system for capturing and submitting the CAT assessment data. It's going to be important to capture this data and then to really use it to make changes in the system, to really see how we're doing, who we're serving in the crisis system. However, I want to say that the data collection is not the first priority in the system. The first priority is that systems are using the tool to really use the tool to work with families and work with other system partners. That's the first priority. Then we will look to developing a data collection system. And I'll talk a little bit more in the next section. So you can move to the next slide. Next slide. Okay. Along with the Maryland CAT tool and developing a uniform assessment for the crisis system, it's also important to develop uniform data elements for the system. So our crisis data collection and assessment subcommittee has spent a lot of time looking at various data indicators and really coming up with a core set of indicators for use across the system. And so some of the key attributes of our crisis data collection and performance improvement system is first to really identify and implement a uniform set of crisis system performance indicators and data elements for use statewide that are focused on outcomes. We'll collect data at a youth and adult level once that's in place. So really at a youth and adult level, not aggregate data. The use of a standardized assessment tool, which we've talked about. Once we are collecting that data, there will be standard reports and a dashboard tool so people can see what's happening in your various jurisdictions as well as statewide. And the other piece is that there's a real commitment that if we're collecting this data, we need to use it. So really to develop forums like this, that we're sharing data and that we're really using to inform and guide system improvements. And that means we really need to develop and implement a coordinated performance review and continuous improvement process. So we're continually using this data to make improvements to the system, both at the local and state level. Next slide. The key mobile response and stabilization measures of success, and we've talked about this earlier in the presentation. Some of the key areas we're looking at within our data collection are really increasing the timeliness and efficiency of crisis service delivery, reducing risk behaviors for youth in the home, in schools, and in the community, reducing the behavioral and emotional needs that youth are experiencing, that we're addressing some of those needs and we're bringing down some of those, reducing risks and really improving the needs picture for youth. In decreasing the use of emergency department services, which Liz pointed out earlier, which isn't the place for youth to be seen in crisis. And also decreasing the number of crisis events that result in inpatient or placements in residential or detention centers. And then increasing the number of children and youth who are referred and successfully linked to community-based stabilization services or resources. One of the key components will be a warm handoff, that we know that children and youth, when they are referred to community-based, are they actually getting it? Are we really linking them up? Because that's critical for them to remain out of emergency rooms, out of hospitals, and sort of being repeat users of the crisis system. And we also want to increase youth and family satisfaction with the crisis response system in Maryland. Next slide, please. So this slide is somewhat busy, but in our crisis work, I'm not going to go into a whole lot of detail with this slide, but we have been looking at indicators across a number of crisis service areas, including call center services, mobile crisis response services, and then crisis stabilization services. We started this work really by identifying indicators from a number of different systems, national data systems, including behavioral health links, SAMHSA recommendations on crisis indicators were part of this. Metrics that are already in use in Maryland by local providers were reviewed in this process. And then our group really has had some robust discussions on which of those indicators sort of are most important for our system. So you'll be able to, there's a link here in this presentation when you receive it that you can review some of this. But when we look at indicators, we're really trying to hit on some of those key outcome areas that I spoke about, really looking at service, some key service utilization, including number who receive MRSS services, repeat users of mobile crisis. We're going to capture demographic information on youth, children, youth, and families using the service, gender, age, race, and ethnicity, primary language. There are measures of operational efficiency, such as the time between the dispatch and the actual mobile crisis team contact. So we'll be capturing, we want to all know, is our system operating efficiently? And then there's a number of quality metrics. So we've talked about referrals and connections and linkages to community-based services, follow-up contacts that are made to ensure that referrals have been made and that children and youth and families are linked to appropriate services. Reduced youth needs and functional status. We'll be using the CAT tool to capture some of the actual outcome data for youth, children and youth in the system, looking at have the needs been reduced during the crisis episode? Are they at lower risk? So we'll have a mechanism through the CAT to be able to look at some individual outcomes. Encounters, we'll also be looking at encounters resulting in emergency room admissions or inpatient hospitalizations. Again, a key outcome for the system. So I can stop there. Oh, actually, one more slide here, sorry. The rollout of the crisis data collection and reporting. Sorry. It always happens. So in terms of the rolling out of the crisis data collection and reporting system, we will be further defining and finalizing the recommended crisis measures in April. We are reviewing the data elements with MDH and BHA leadership to obtain their approval to move forward. So there's going to be some more work refining and operationalizing some of the measures. And as Maria talked about, we'll be implementing some of those measures within our conditions of award documents for crisis services. In May and June, we'll be looking at rolling out an interim monthly crisis data collection to get things started. With these elements, it won't be the full system. And that, through the summer and fall, we'll be working to really design and develop the functional specifications for a more robust, youth and family focused data collection system, working with our MDH IT and our IT folks to really develop that system. It may be linked with other systems that are already out there, or a system that's designed internally that has not been decided. Going further, once we have that system trained, we'll be training crisis providers and stakeholders on the use of the data and reporting system, and really implementing the data system statewide. And that would be through the spring and summer of 23. So it's going to take a little while to get the data system up and going. And I will end there.
Thank you, Jay. So that's the end of BHA's section. So we'll open it up to any questions to BHA. And there were some questions in the chat that maybe, Maria, you could just summarize. They're all related to funding.
Yeah, I maybe that's just a good segue into a little bit about where we are with sustainability. And the big answer is all the pieces aren't worked out. We don't have absolute answers. But I did want to highlight that we did receive the CMS Technical Assistance Grant, working with Medicaid very closely on that. The purpose of this is to help us be able to find a pathway towards this, to be able to utilize the enhanced federal match from Medicaid for mobile crisis services. And as we come up with solid answers for that, we're working with consultant health management associates around this. But as we come up with answers to, what can be included in that, and that's a bit of a moving target, and how much that is going to cost the state to provide this broadly, how much of that we're going to get back in terms of federal match, it helps to answer some of the questions about longer term sustainability. But just to really highlight that for anybody who is Medicaid eligible, we are going to be getting the ability to put this in as a fee for service. And that's going to really change the cost analysis for all counties, for all regions as we roll this out. That's the lifespan. And we're already beginning to work towards how do we bring in the commercial players as well. Those that are familiar with, I don't know whether it's being called the ombudsman bill but the very large, very comprehensive bill that was posted to this year's session that includes everything in the kitchen sink. Included in that is, bringing some expectation that the commercial providers are working towards funding towards this as well. So it goes back to there are a lot of moving targets, but we're absolutely working in close alignment with the broader BHA crisis group around this for children. And children, youth, young adults, this is the model that's being promoted. Obviously, all the stabilization isn't going to be a part of that mobile crisis billing code, but we're looking to have as much as we can and look to say, how do we bill for other sections as well? Even if it's not getting the 85% match, it still would be getting the 50% match. It just kind of reiterating that within BHA is a broad crisis work group. There are many subcommittees under that. Jay and his team is obviously leading the data one. There's a completely separate committee that is the sustainability work on this. And a key component of that has been, this technical assistance grant that we got from CMS and how we move those pieces forward. So, question just caught my attention around the call center. I think that the call center, I'm going to at the moment say that is being sort of a separate entity. Kathy Weber Franklin and her group, again, another one of the subcommittees under the broader BHA crisis plan, is working to get additional funding for that. We know there's additional funding again coming through the pipeline for that, but we're sort of allowing them to work through the funding of that call center and using that to support, the MRSS in the child space.
Great. Any other questions? We have probably 2 more minutes if folks want to ask anything in the chat or just come off mute for a minute. Okay. We're a couple minutes ahead of schedule, which is wonderful, but close. Just checking in, Kim and Denise, if you're ready for your slides.
We're here.
Great, thank you. All right, I'll pass it to you all. Thank you.
Great, thank you. And you all did introductions earlier, so I am Denise Solzbach. I know many of you. It's so fun to see familiar names in the participant panel. Those of you who don't know me, I worked for BHA in the early 2000s. That sounds really weird. Fortunately, we don't age in the state of Maryland, right? And I do National Center work with Kim and Liz and others at the Institute. Kim, you want to introduce yourself?
Sure. Hi, I am Kim Estep. Apologies for being late. I was on another training this morning. It is great to get to work in my own state sometimes. So thank you all for having me. And I am faculty at the university as well as the director for the Division of Implementation and Workforce Development at the Institute.
Thanks, Kim.
Mm-hmm.
Morgan, can we have the next slide? And we have another poll for you. So Jay talked about the key mobile response and stabilization measures of success the state's exploring. What we'd like to know from all of you in your counties and your jurisdictions, what are those issues? What are problems you're trying to address through mobile response and stabilization? What in results-based accountability talk, what's the curve you're trying to turn? And you can select more than one answer. Oh, I'm sorry. Nope, we can select one choice. So what's your top curve that you want to choose? We can chat more. Put your second, third, and fourth in the chat box because we know there's a lot of them. Yeah, emergency room visits are a hot number. Inpatient, equity, school. Keep them coming. Thank you, Audra. Audra's chiming in the chat as to inpatient and residential are 2 and 3. Please, others, pop in. Audra, great to see your name. Right back at you. Okay, great. Thank you. So number one is ER visits from this group. Let's end the poll. And Kim, let's talk implementation science.
All righty. So implementation science, just real quick, is sorry, the poll is popping up several times for me. The implementation science really is about best practice approaches to installation. So it's not necessarily about MRSS specifically, but it's about any kind of reform effort or things that systems are undertaking, to make things better. And so we know that there's actually a better way to do it. And so we just want to outline a few of those things, just so that in your minds, as we're rolling out this across the state, kind of fast and furious, just to remember a few key components. And so the first of those is really identifying the need. And as the chat indicated, there's a lot of diversion from emergency room. There were some decrease of school suspensions and other things that were selected. But how as a state are we defining that need, and what are the data that we have to support it? Meaning, what can we track? What can we say, this is actually the piece that we want to turn the curve around? And then how are we going to know if things are getting better? So Morgan, if you could click, I'm sorry, it's animated. I should have just unanimated it. And so from there, we're defining the outcomes, right? And so part of the outcomes could include our families together, is there an improved well-being, but then also those indicators that you all selected and prioritized, how are we tracking those? And are we actually turning the curve on emergency room visits or residential stays, school suspensions, and so on? And do we have a skilled workforce? Is there a comprehensive provider array? And those are just some examples. And then from those outcomes, we want to move to fit. And when we talk about fit, it's will the thing that we're installing, in this instance, MRSS, will that thing that we're installing actually move the needle on what we're hoping to turn the curve around? And I'm really hopeful that that will happen, and that MRSS will actually turn the curve on emergency room visits for behavioral health needs and so on. And so as we're aligning kind of diagonally across that and making sure that we've identified the needs, that outcomes are clearly defined, and we have a way to track them. And then we know that the intervention or the model or the thing that we're doing, the reform effort that we're undertaking, is actually going to meet the need and address the outcomes. Then we want to make sure that the outer setting, things like financing, policy changes, leadership, system design, and so on, are in place. And then in our inner setting, that we have the needed provider types with the right qualifications, we have the right folks doing the work, that we're addressing workforce development, and we're monitoring the implementation and the quality of the work that's happening. And then to bring all of these pieces together, there are bridging factors. And so there's partnerships, there's many state systems represented here, plus the University of Maryland. And so what are those needed partnerships if they're not already represented? That there's expert coaching, and that we're really working closely to close the gap between policy and practice. And so all of those things coming together are really important. And if you wanted any of those elements clearly defined, I'm not going to walk through that with you, but there's a slide with some short and sweet definitions of all of those pieces. I think the thing to note here as we're looking at the implementation science framework is that there's a pre-implementation, implementation, and sustainment phase of this work. And I know Denise and I are going to talk about readiness, and I'm going to turn it over to Denise, which squarely sits in the pre-implementation. And are we ready, and what are we doing to get ready? And then there are also indicators around implementation and sustainment that we would also want to track over time.
Great. Thank you, Kim. We have one more poll for you. So Jay talked about data tracking. We're interested in knowing what's your confidence right now in identifying reporting data to track whether we are turning the curve on your identified needs. Somewhat? Excellent. So we have a lot of confidence going on and nobody's not sure. So this is great. Fantastic. Keep them coming. All right, the somewhat confident is the overarching choice here. Great. Okay, thank you, Morgan. We can take down that poll. And I just have to get rid of it on my screen too. So Jay talked a lot about indicators for the services. And so what we also want to make sure that we're looking at are the readiness factors. So in addition to establishing data markers as the baseline for reform and demonstrating impact on turning the curve and addressing the identified need, it's really important to ensure readiness and hold ourselves accountable for achieving the readiness necessary to support effective installation. So the readiness assessment we're going to use is an adaptation of our system reform support instrument. And it's intended to support, as Kim indicated, your pre-implementation readiness for mobile response and stabilization. It's going to be used as part of ongoing technical assistance that Jen will talk about. And we're looking to track indicators across essential systems and program components for successful installation of mobile response and stabilization. And Liz showed that slide to you that had the family and youth program pathway in the middle, and then the system pathway and the program pathway on the top and bottom, really indicating what are those, that's that hospitable environment that we need in order for that program pathway at the child and family level to be successful. And as Jay indicated, with all of our CQI and rapid response plan, do, check act, we want to be able to hold ourselves accountable at the system and the program levels, supporting ongoing monitoring and evaluation of our reform effort, as well as the foundation for sustainability that a lot of you are focused on for the chat box. So we're going to do this by using the readiness tool with indicators by which we're going to rate ourselves for each indicator: 0 not in place, 1 partially achieved, and 2 fully achieved or in place. And the indicators we're going to look at are grouped in alignment with implementation science that Kim just went through. They're going to be looking at need. Has a problem been identified? Has your care pathway been designed? Fit. We're looking at population definitions, mobile response determined to be turning the curve. Outcomes, measuring to track outcomes and fidelity are established. Data collection, tracking mechanisms are in place. When it comes to the outer setting, we're going to be looking at vision, financing, leadership teams, screening and assessment tools, care standard practices, CQI. And then in the inner setting, we're going to be looking at training and workforce development, staffing model, provider qualifications, feed loops, and policy review. So let's look at the next slide. And this is the slide that Liz shared with us. And as she highlighted, this is an example of a family and youth mobile response and stabilization care pathways. Those dots represent what needs to occur at the local and state levels to ensure that the success of the care pathway, right? So they represent policy and management indicators to ensure coordination across systems, shared decision-making, clearly established care standards, as I mentioned on the last slide, ability to fully leverage and optimize resources. And then also you see indicators there for the community and practice realm to enhance quality and consistency of the practice, increase satisfaction, and ultimately improve outcomes for children and families. So that this readiness tool is going to help us populate this wave around your family and youth care pathway. And once we connect and place all of those dots, populate those dots, that's creating that hospitable environment, our responsibility at the state and program level in order, the system and program level in order for that care pathway to be successful. Morgan, let's go to the next slide. So the work that you'll be doing with Jen is part of what we like to talk about as why first thinking, rather than starting with the what, mobile response and stabilization, and just throwing it up on the wall like a wet noodle and hoping it sticks. Why first strategic planning relies on the use of data to first dig deep to fully understand the reasons why youth and families are experiencing care pathway interruptions that Liz spoke about. Using data, as Jay spoke about, to drive change based upon fact, not feeling, allowing systems to intervene with those innovations and program model interventions through mobile response and stabilization that are fully responsive to the identified interruption points and result in those new care pathways that will best support children and families that Liz discussed. So we're starting with the why, identify and agree upon the problems. We did a little bit of that in the chat and through the polls. with your existing care pathway. What do families experience? What do we need to know about what we're doing wrong in order to identify those interruption points? Then we're going to look at the what. We're going to use data to understand those interruption points. And step 3 is to map those new care pathways. It also includes establishing those data marks that Jay talked about. And it's really important to consider which systems need to be included in the intervention design and implementation of mobile response and stabilization in order to achieve the desired impact and reach that Liz discussed. Defining the what requires systems leaders to do the research, evaluate, and optimize strategies to determine what's that's most likely to disrupt that care pathway and identify your interruption points. For example, do services in your county need to be added to the service array, or do existing services need to be made available sooner? Or are there opportunities to leverage other initiatives across and within your child serving systems? And then we're going to look at the glue between the what and the why, and that's the how, which is that wave on the last slide that surrounds the care pathway, the work that we have to do to ensure that the care pathway leads to turn the curve and achieve the identified outcomes that you want for children and families in your county. And that all starts with the readiness assessment, and that's where Jen's going to step in. Yep, you're on mute.
Thank you. Thank you, Denise and Kim. I appreciate you framing this conversation of the TA, and for those that we've met with, you know, this really provides a framework to have a method to the madness. This is a really complex implementation in Maryland, and we now have really good a good framework to move this forward. So I'm here to help you all with this transformation, which is huge, using these tools. And the practice change that we're really trying to achieve is the following here, which I'll walk through. Prioritizing the voice of parents and caregivers and youth and young adults in determining the crisis and the action steps to meet youth. Creating those conditions that Liz spoke about to allow for shifts in language and cultural factors necessary for parents to reach out for assistance. Assessing those best practice components and principles in practice that are in practice now and that need to be achieved. Focusing on creating an access point that's easy for parents and caregivers to get assistance with the most minimal stigma. Creating feedback loops and outcomes that focus on meeting those needs. Engaging communities and relevant stakeholders in supporting children, youth, and families. Very importantly, creating equity and access, workforce, and service delivery. And focusing on interrupting those pathways that lead to restrictive services and trying to get children to not go to ER when families are desperate. So that's what we're trying to transform and work towards. I have met with several counties and with support in conjunction with BHA to start forming those implementation teams to do that work, to really determine the readiness, where you are, where you need to go, sharing the design, BHA's design, supported by this larger statewide collaborative, starting to look and discuss data and utilization at local levels, problem solve. We've already jumped into that and made some local decisions on where your counties are and where they need to go, and really staying in line with the statewide vision that BHA has set out. And to continue to gain knowledge on the national best practices, which we will continue to talk about each time we meet and each time we come together in this larger group. Next slide. I have, again, with BHA, met with several counties in February and March, and have several more counties lined up the rest of this week, as well as into April and May, to begin to have this conversation, to begin to do this readiness work. Next slide. Just to refresh folks' memory, and for those that perhaps haven't actually had a lot of experience with receiving TA, the reasons for TA specific to this intervention, MRSS, is to provide that statewide vision and bring it to the table and make sure it's understood. Again, aligning with best practice education and training, supporting that strategic planning, building those implementation teams, assessing the capacity and the current work that's being done, really beginning to set evaluation and data collection processes, identifying partnerships, which is critical in our early conversations. Are you talking to child welfare in your jurisdiction, school systems? What are those relationships? Make those peer connections with partners doing similar work, whether it's across county or it's within a county. Engaging in that statewide initiative, understanding, and coming here today is how you can stay engaged. Establishing funding opportunities and talking to what we've talked about, what you have and how to braid funding and create financial stability and sustainability. Continue to address the cultural linguistic equity needs and to talk about social marketing. You can design a great system, but if nobody knows who to call, then that is a sticking point and needs to be worked on. Some of the larger system outcomes that we hope to achieve and help you all achieve is understanding the adoption of these best practices, creating new or increase your capacity for MRSS, enhancing those partnerships, forming something very important, oversight and governance. Who's owning this process? Who knows how it's working? Who knows that children and families are being reached properly? Talking about some implementation strategies as we go along. Very importantly, also establishing a CQI process, making sure folks understand what that entails and how to do that and have that feedback loop with data. And then addressing policy and procedure analysis and revisions as needed. Are your policies supporting this practice and implementation of mobile response and stabilization? So those are reasons and outcomes to hope to be achieved, and we can talk through at each of our TA meetings that we are holding. Next slide. As Kim and Denise mentioned, we are in the thick of the pre-implementation phase of this work. We have had some conversations with early counties on engagement. We will move into feasibility in stage 2. We will start using the tool that was described by Denise, and then really move into readiness planning to move folks through this implementation phase. Each county is in a very different place. And so we are starting where each county is to understand, assess, and then move forward to create TA action plans. This entire individual local TA structure is then supported by this to reiterate what's been heard and what's being done at the local level, and here to answer any questions at the statewide level as we hold these meetings every other month. Next slide. Call me. I'm here for you. We are available to provide TA to every jurisdiction out there, and appreciate those that have stepped up early to have these conversations and will continue to do so. So here's my contact information. Before we move to larger questions or general questions, and we can ask some specific TA ones or make available TA questions as well, I want to just share with you before it's lost the resource slides, and in particular the first one, the National Association of Mental Health Program Directors learning community that is available for sign up. So I just want to make sure folks see that, as well as 2 other slides containing other general resources that may be helpful to you all as you work through this in each of your counties. I think I'll take a step back, or not step back, but just pause for a moment to see if there are specific questions related to technical assistance that you can ask Denise, Kim, or myself. And then we can move back to larger QA questions. We do have 15 minutes left, so that's great. So a little time to answer some questions. So anything related to TA or the slides, specific slides that were presented by Denise and Kim. Either it was crystal clear, or it's just overwhelming. I don't, it's a lot. So Denise, jump in. I see you came off mute.
Well, I was just going to give a little bit more of a commercial for the NASHFIT Mobile Response and Stabilization Learning Community that we're running. So that's free. It's a great opportunity to bring some of your partners to the table as well. I'm not sure how much Jen has covered this with you before, or Michelle or others, but the Institute has been facilitating a discussion for SAMHSA, developing a children's crisis response toolkit. It looks like that toolkit is going to land on, unlike the adult model, someone to contact, because we want to encourage texting as well, someone to respond, and a system to support. So the first 3, and Liz can jump in too in case I leave any details out, the first 3 learning opportunities through the NASHFIT series is going to cover those 3 components that will be coming out in the SAMHSA toolkit. Fingers crossed, we're trying to work our way through SAMHSA clearance. So just encourage you to join that learning community because it's free and it's a great one.
She got that right.
It's great. Thank you.
Please join us. I think it'll be interesting for all of you.
Any other questions related to TA? If not, we can move back to any general questions you can put in the chat, or you can come off mute. You will definitely receive the slides, so we'll get that to you all, as well as the 2 documents that are newly released as well. It'll be on BHA's website. And thank you, Joanna, for posting or putting the link in for the KIS website, as well as the BHA website, which folks can go to as information is posted. Yes, there is a link on the resource slide. It's the first item on the resource slide that you can click on to enroll. Thank you, Shauna. I'd like to give Maria and Jay an opportunity as well. And Liz, anything else you'd like to raise today? Otherwise, if folks really don't have any questions.
Well, I would, this is Jay. I would just add that if people, I know a lot of information was presented today around a whole lot of different pieces of the planned crisis system. But if people have questions about the data collection or use the CAT tool, please feel free to reach out to me. I'm happy to meet to talk to you about this in more detail.
Great. And Morgan just put the link for the learning community in the chat, so you can grab that as well. Well, I don't want to stand between you all and starting your work week. So I really appreciate you all joining on a Monday morning. It's the first time we've done this. So hopefully you had your coffee and your tea and were able to start your week with some new information and some relationships and conversation. So Maria, any other closing thoughts from you?
Probably just, sort of continuing to thank everybody for going along this roller coaster with us. It's an evolving process. It's a rapidly evolving process. We have more questions than answers, but we're all here doing this, and we know, as a goal what we have, and that's a great goal, and we're going to get there.
Well, thank you, Maria. All right, well, thank you. You'll get the slides, you'll get the documents, and please think about signing up for the learning community, and we'll be in touch with folks as we have many meetings scheduled with you all. So thank you so much. Take care.
Thank you.
Okay.